Welcome to the last Talk with the Doc of 2022. No worries, Dr. Leichliter will continue Talk with the Docs in 2023 and hopefully beyond. I'm Casey Peluso of Parkinson Foundation, Western Pennsylvania. I think I'm joined by my colleagues, Christine Haythorne, CEO, and Lauren O'Neill, our Marketing and Design VP. And there are some questions that were received ahead of time, and then you can submit questions using the chat box during this live talk. Thank you, Dr. Leichliter, Movement Disorder Specialist of Allegheny Health Network. And take it away.
Done. Thanks, Casey. Well, welcome back, everybody who's been here before, and welcome to anybody who's new. For those of you who don't know me, I'm Dr. Leichliter. I'm a so-called movement disorder specialist over at Allegheny Health Network. A couple of things that I always cover ahead of time are, first and foremost, is one, this is going to be basically general information. So if you do have questions, type them into the chat box. That's the best way to get it in. This is not a great place for individualized care. So, don't say, hey, I've had this, I'm on this, what do you think we should do next? That's a great question for your doctor. One of the themes of my talks is you should really have good communication with your doctor. Doctors are hard to communicate with. I make no mistake. I understand that I'm not always the easiest person to find, but you have to be able to get messages to and from your doctor for things like that. The other thing that I always warn people about for this talk is that everything you hear is my opinion. My opinion, well, I always think my opinion is right, but everybody does. But my opinion is just that, my opinion. It may not be exactly the same thing as your neurologist or your movement disorder specialist's opinion. Although I like to think most of what I tell you is based on as good of scientific evidence as I can come up with. Sometimes there is no scientific evidence, so I make it up, and usually I throw up some air quotes to let you know I'm making stuff up. But that being said, if you have a neurologist or you go see somebody, not me, they'll give you their opinion, and our opinions are probably going to be similar, but they may not be. And so you have to take what I tell you as my opinion, nothing more, nothing less. We did get a few questions sent in via email, so I'll start with those ones and give you guys a chance to type in some questions, and then I'll attack the questions in the chat box, and then we'll go from there. And like I said, welcome to anybody who doesn't know me or hasn't been here before. We're going to have some fun today. All right, so the first question I got was about pain. So I have pain in my right hip and down my leg. At times my foot curls, or my foot turns in and my toes curl. I seem to walk on the side of my foot. It's painful. Do you think it all stems from my hip? Again, not that without examining you, I'm not going to be able to really answer that question. Or is dystonia a separate item? Can this be reversed? Is there certain medicines for dystonia? So there's actually a lot of questions in that question. And so two things. One is pain is a fairly big problem in Parkinson's disease. And now the hard part about pain in Parkinson's disease is that there's a lot of types of pain. And not all pain is created equal, and not all pain is treated equal. You can have pain purely from Parkinson's disease, and this is probably the hardest pain to treat. It's just that things hurt. Sometimes it's because muscles are tight. Sometimes it's from dystonia, which is toe curling or foot turning in or hand clawing up. Sometimes it isn't. Sometimes it's structural, meaning, again, a lot of my patients, because their mechanics aren't right, they end up with a lot of hip and knee and back and shoulder and ankle problems and neck problems, because when your mechanics aren't right, your joints don't work correctly. And that puts a lot of stress and strain on a lot of joints. And so a lot of my patients end up with joint pain. You can have dystonic pain, which is really cramping of the muscles. And so you can get neuropathic pain. So a lot of my patients get neuropathy as well as Parkinson's disease. And so there's a lot of different kinds of pain in Parkinson's disease. Dystonia is just one form of it. The hard part about pain is teasing out the type of pain that you have. And so if pain is from a joint problem, I treat it very differently than if pain is from a neuropathy problem or pain is from a muscle problem. All of these can cause pain, but they're all treated very differently. And so trying to get to the underlying cause is really what we aim for, what we try to accomplish. I ask you a bunch of questions like, what's it feel like? Is there any relationship to your medicines, particularly with dystonic pain? A lot of people notice that, hey, my foot turns in and my toes curl when my pills wear off. Well, then you don't need pain medicine, you need more Parkinson's disease medicine. Or There's a rare occasion where you can actually get toe curling or dystonia when your pills are overshooting, in which case maybe you actually need less medicine. And so the long story short, or the long answer short to that question is there's a lot of different types of pain in Parkinson's disease. And the best way to try to tackle those is to try to tease out what's causing it and then treat it appropriately. If you really are having toe curling or your foot turning or what we would term dystonia, and the word dystonia is a tough one because dystonia is really just a description of movement. It's not actually a very definitive diagnosis, meaning it doesn't tell you anything about the underlying cause or what it is. It just tells me that you have abnormal muscle contractions leading to fixed or twisting postures and tremors. That could be a standalone condition. It can be part of Parkinson's disease. It can be a side effect of medications. It can be from a lot of different things. But if you really are having dystonia, the first question is going to be trying to tease out, is it medication related? Is it a wearing off dystonia, meaning as your pills wear off or you're due for your next dose of medicine, that's when you start noticing it? Like I said, is it a peak dose dystonia where your pills kick in and maybe you have some dyskinesias? That's when you get it. That's a good way to try to first start with, okay, how do we tackle this problem? And then the last part of that question is, are there any specific medications that we use for dystonia? And there are. So there's a couple. So not only do we try to adjust the Parkinson's disease medicines, the levodopa, the Mirapex, the dopaminergic medications, it turns out acetylcholine is particularly important for muscle contracting. And so the medicines that block acetylcholine tend to be the ones that we use for dystonia. If you block the acetylcholine from acting, it blocks the muscles from contracting and it relaxes muscles. The downside of this class of medicine is their side effect profile stinks. They cause a lot of side effects, particularly brain fog, confusion, things like that. And so I'm hesitant to use them because, again, they do have not a great side effect profile. The alternative would be something like Botox injections. So this is a time where I'll use injections. Botox is a more focal way to block, the release of acetylcholine or prevent those muscles from contracting. And so if it is more of a constant or progressive or continual, fisting of the hand or turning in of the foot or curling of the toes, sometimes we can get away with injections to try to help with that. Again, this is all very individualized. And so if you're having a lot of these problems or you're noticing a lot of these problems, then at the end of the day, the best plan is to bring it up to your doctor, talk about it with your neurologist, again, armed with the information of, is this related to your medicines? What does it feel like? When is this impacting you? Kind of all of the information that I would need to decide, okay, this is the best plan for it. And then we can kind of come up with a better game plan for how we can work on it. But again, pain is not an uncommon thing in my patients. Sometimes it's dystonic, sometimes it's other. And the good part is a lot of times we can do something about it, but the key to success is figuring out what you're dealing with and figuring out what to do about it. The next question I got was about general anesthesia and Parkinson's disease. And so the question was, does the length of time under general anesthesia make a difference? For instance, would a 30-minute surgery be less risky than a 3-hour surgery, or is any use of anesthesia should be avoided if possible? Now, this is not known. There's actually not a lot written out there about general anesthesia and Parkinson's disease outside of the fact that the general rule of thumb is that we think it's not good for the brain. There's more written about general anesthesia in things like Alzheimer's disease than there is about Parkinson's disease. And so we do extrapolate a little bit here. I did an unpublished study when I was a fellow trying to compare cases done under general anesthesia versus cases done via other types of anesthesia. Now, it wasn't a great study, which is why I never published it, because we weren't exactly comparing apples to apples. Generally, general anesthesia is used for cases that need general anesthesia, and local or spinal anesthesia is used for cases that don't need general anesthesia. And so we're comparing more severe surgeries, which usually are bigger surgeries, or longer surgeries, which usually need more general anesthesia, with either smaller, more minor, or shorter surgeries. But it turned out that general anesthesia was kind of correlated with about, if not a third, if not a half, at least a third of the time worsening of symptoms, whereas more local was closer to less than 20%. And so there was a difference when I actually did this and looked at it. Again, the data wasn't clean. It was not a perfect study, which is why I never thought that it was necessarily publishable. But it does show that we know that anesthesia of any kind really does play a role in the brain and nervous system. So believe it or not, your brain was not meant to be shut down and woke up artificially. And coming back to your question, I do think there probably is an additive effect, meaning the more anesthesia that you get, the longer the surgery, probably, now I'm making this up, this is my opinion, probably the worse it would be. I can't say that for any certainty, but the short answer is most anesthesiologists and most surgeons know, hey, the least amount of anesthesia I can get away with is probably the best for most people, but also people with Parkinson's disease. If they can do it via spinal or via non-general anesthesia, my opinion is that's probably better from a brain standpoint, although I don't have any evidence or direct, scientific literature to back that up. But just in kind of what I've seen, general anesthesia is not great for the brain. Now, again, this does not mean don't have surgery if you need it, right? It just means, and as far as I know, they're not just going to give you a shot of whiskey and a stick to bite on anymore. They're going to knock you out if you need to be knocked out. And if that's the case, if you need the surgery for whatever reason and they need to do general anesthesia, so be it. We'll figure out the rest after the fact. And I would argue, or I would say that most surgeons and most anesthesiologists do as little as needed. I can't think of many patients that I've seen recently where they had either a longer surgery than I thought was necessary, or they were overly aggressive with anesthesia. I mean, that's just not the way that things are done. And so as little anesthesia as you can get is probably best, in my opinion. But if you need surgery and you need general anesthesia, I think it's a worthwhile trade-off, and we just have to pick up the pieces after the fact. The next question that I got was about Azilect. So Azilect or rasagiline is a monoamine oxidase inhibitor. It basically is a supplemental medicine to carbidopa-levodopa to try to help people do better. It's a good medicine, but it's a fairly weak medicine. The one benefit that it has over most of the medicines that I have is that it's once a day. So the questions were, what's the best time of day to take it? Can you take it with carbidopa-levodopa? Can you take more than one per day? How many hours of relief do you get? And there's a lot of questions here, but the short answer is it's generally once a day. There was a study where they looked at a 0.5 milligram, 1 milligram, and 2 milligrams, and it was the 1 milligram pill that really did the most benefit. So it really is just a 1 milligram pill once a day. That's how I use it. You wouldn't use it more than once per day. You can take it, theoretically, it's a 24-hour pill, although its half-life is much shorter than that, but we think it lasts for 24 hours. So it shouldn't matter if you take it morning, afternoon, or evening, as long as you're taking it consistently. I don't think people have ever told me, hey, it makes me tired, or hey, it doesn't let me sleep. But if you find that, then adjust it accordingly. And I do use it periodically, again, especially when I'm trying to give people a little bit more benefit. I don't want to add in a tremendous number of pills. It's one of the ones that I'll come to, and it's not a bad choice. What are my thoughts on the inhaler? So again, another question. I like the inhaler. So Inbrija is inhaled levodopa, which is a rescue medicine. Used to help when people have unpredictable offs or wearing off all of a sudden. I prescribe it sometimes in those circumstances where I think it would be beneficial. I have had people have success to it, just like I've had success with Apokyn and Kinmobi and the other rescue medicines. And we pick and choose which one we want to go with or what the right one is for you individually. In generally, people tolerate it pretty well. Sometimes the inhaler makes people cough and they don't like that, but for the most part, I've had people tolerate it fairly well. And so I would say it's okay. I would love to have, new medicines, as opposed to people keep giving me different versions of the same medicine, but maybe I'm asking for too much. I have to rein in my expectations or my desires with the known research community. And so I'm never against having more versions of the same medicines, and a different way to get it into people is always nice. So that has its plus. But at the same time, I'd really like to get more different medicines so that we could try something new, see if we can come up with something disease modifying. I do have high hopes, and maybe my expectations are a little bit too high on that one. But again, that's kind of my idea on the inhaler. And yes, I do prescribe it periodically. What do I think about seeing a geriatrician versus a regular primary care doctor? Well, that's an interesting idea. I don't know that there's that many geriatricians out there, but believe it or not, I do get I think we have a geriatric training program here at Allegheny Health Network, and a lot of those residents are just doctors in training, do tend to float through my office because I do tend to have a geriatric population. I'm not telling any of you guys that you guys are old, but I do tend to have a geriatric population. And so they tend to rotate through my office. And I do get the impression that having a geriatrician does give you a little bit of an added benefit. They tend to have a better, their head wrapped around, what geriatric patients or elderly patients need more so than dealing with kind of younger people. I think they're a little bit better at thinking about quality of life more so than maybe, every new and advancing thing that comes up, but maybe I'm wrong about that. That's just kind of my opinion. I just don't know how easy they are to find. I don't know how many of them there are, how what the, rate of keeping them in Pittsburgh is. And so I don't think you necessarily need one. You do need a primary care doctor of some sort. I am not a very good primary care doctor. And so at the end of the day, I definitely want all of my patients to have a primary care doctor. And I bet your neurologist thinks that too. We do not make very good primary care doctors. And so you do need a PCP. And if you have a geriatrician in its place, and maybe that gives you a little bit of added benefit, but if you can't find one, then I think as long as you have a PCP, you're probably doing okay. I think that was all the questions that got emailed to me in advance. So let me go back and start tackling the chat questions here. Don't worry, it's just tea, nothing stronger. All right, ketamine. What are the benefits and problems with this medicine? Well, that's a good question. I don't have a lot of experience with ketamine. So ketamine is approved and used predominantly in the pain world and the depression world. So the psychiatrists are probably the ones who use the most ketamine. It's also been dabbled in headache medicine. So with infusion, sometimes the heavy duty migraine clinics will do ketamine infusions. I'm not sure we do it here, but I think they were trying to do it in our headache clinic over at West Penn. I have not seen it used in Parkinson's disease. My guess is it would be useful in people who have Parkinson's disease, but also have depression or other mood disorders. I mean, I think the risk is it's kind of an upper, so it could, increase blood pressure, heart rate, that kind of thing would be my guess. But since I've never actually used it or prescribed it, I can't pretend that I know all the ins and outs about ketamine or the side effects or the risks. The downside is again, even if, and I haven't looked it up, but even if it is useful in Parkinson's disease, I think we're going to be hard pressed getting it. And so I think the jury's still out on that one. I'm sure somebody's probably studying this somewhere because, again, they do look at a lot of these types of things in the movement disorders and Parkinson's disease, particularly in patients who do have depression or other psychiatric conditions. But I'll have to look that one up. I haven't seen it used. I haven't seen it approved. I haven't even really seen any studies on it. So I would say from my standpoint, the jury's still out on that one. If stiffness and muscle pain are caused by Parkinson's, would a corticosteroid give relief? Maybe. And it depends on what you mean by caused by Parkinson's, because Parkinson's can cause literally everything. So steroids are good for inflammation. And so if you have inflammation, if you have arthritic knee, if you have arthritic spine, if you have inflammatory condition, steroids tend to help with that. This is why they'll do steroid injections for kind of a lot of arthritis in the knees. It tends to decrease inflammation and help from a pain standpoint. Now, as I mentioned, again, it's not uncommon for Parkinson's disease patients to have a lot of joint problems, right? God or whatever higher power you believe in really did put us together correctly the first time. And our joints are set up to work in a certain fashion. And they're set up to work in a fashion of normal movement. So when you don't have normal movement, and I would argue that anybody who has Parkinson's disease does not have normal movement, ends up not using their joints correctly, ends up putting a lot of stress and strain on their joints, and leads to a lot of joint problems. So again, when you come down on the front of your foot or you have a shuffling gait, That's not how you're meant to walk. Your ankle and knee and hip are not expected or not built for tolerating that type of repeated pressure in an inappropriate plane. And so that's why a lot of my patients end up needing knee replacements and hip replacements and back surgeries and shoulder replacements and so on and so forth. So if you had that kind of pain, and you could argue that that kind of pain is coming from Parkinson's disease, would a steroid benefit you? Maybe. I mean, again, that's what we use steroids for in terms of joint injections, things like that. But if you're talking about stiffness or cramping or dystonic pain, which is really more of a muscle contracting problem, then I think you're going to be less successful with corticosteroids. Again, you really need to give something to relax those muscles, to allow relaxation, to allow that pain to relax. And I don't think a steroid would do that. Again, it would definitely decrease the inflammation, but I don't think it would actually relax the muscles. And so I think it would be less useful for that. And so the short answer to or the end of a long answer, the short end to a long answer of a question is, coming back to pain, you really have to figure out what type of pain you're dealing with, because I would treat, joint pain very, very different than I would treat dystonic pain, very, very different than I would treat neuropathic pain. Dystonic pain, I would try more dopamine or acetylcholine medicine. Joint pain, I would go more steroids or typical anti-inflammatories. Neuropathic pain, I would go gabapentin and Lyrica. And so getting to the underlying cause is really how you get to the underlying treatment. And so that's how I would kind of look into that. What is dysautonomia? Dysautonomia is a tough one. So dysautonomia purely means problems with your problems with your autonomic nervous system. So what is your autonomic nervous system? So your autonomic nervous system, or your automatic nervous system, is the nervous system or the part of your nervous system that controls automatic things. So believe it or not, just about everything in your body is controlled by your nervous system. There are some things that you have to think about. Hey, I want to lift this arm up. There are some things you don't have to think about, like, hey, my heart should keep beating, right? You don't want to have to think about stuff like that. The autonomic nervous system is what controls the things you don't have to or don't want to think about. Blood pressure, heart rate, sleep, going to the bathroom, things like that. Things that are generally outside of thought. They just happen. Well, nothing just happens. You need your nervous system for things to happen. And that's what the autonomic nervous system does. It controls the automatic processes in your body. And yes, just like the more normal nervous system that we talk about, the tremor and the stiffness and the other muscle type of nervous system, the autonomic nervous system can dysfunction as well. And this is where you get the term dysautonomia. We generally think about dysautonomia and Parkinson's disease in terms of blood pressure, in terms of urinary problems, things like that. Probably the most obvious example of dysautonomia is something called orthostatic hypotension, which is when you stand up, your blood pressure goes down. And why that happens is when, and we'll say normal people, I don't know any normal people, but if there was a normal person, theoretically, when that normal person stands up, all the blood rushes to their legs. They have receptors up here in their carotid artery or carotid bulb that kick in, increase their blood pressure, increase their heart rate, and make sure they keep pumping blood up to the brain, which is where you need it to be. That's how it's supposed to work. When it doesn't, so when you have dysautonomia, or when your autonomic nervous system isn't functioning correctly, say in Parkinson's disease or multiple systems atrophy or something like that, you stand up, all the blood pools into your legs, and those receptors don't kick in. Your brain doesn't get blood, your blood pressure goes down, and you get lightheaded and you pass out. That happens in Parkinson's disease. Your autonomic system can be affected. It's more prevalent or prone in something called multiple systems atrophy, which is a Parkinson's plus condition or a Parkinson's disease-like condition, but it can happen in Parkinson's disease too. And at the end of the day, it's pretty disabling. So again, if you haven't had this happen, you can imagine how bad it would be that when you stand up, you pass out. Or even if you just stand up and get lightheaded or dizzy, that's a very disabling symptom for a lot of my patients. And it's a really hard problem to fix. Sometimes and the medicines that we use in Parkinson's disease, particularly the carbidopa, levodopa, sometimes make it worse. A lot of my patients who start off on medicines for blood pressure, say they come in, they say, I've had high blood pressure my whole life. I'm on 4 medicines. As Parkinson's disease progresses, or as we try more and more medicines, a lot of times they have to come down or even off of some of those medicines because blood pressure can be affected. Sometimes we actually have to use medicines to try to boost blood pressure. And then we run into the very not fun game and battle of trying to get it up, but not too high that it causes a problem, but not too low. And so we try to play Goldilocks, and sometimes we have success and sometimes we don't. It can also affect going to the bathroom. We think that's kind of the autonomic system. It doesn't usually affect heart rate as much, but you can get some heart problems as well in some neurological conditions. And so when you hear us use the term dysautonomia, which I don't use a lot of, but if you hear us use the term, or you hear the term dysautonomia, it really is the autonomic nervous system, the nervous system that controls automatic things, and it can be impacted in Parkinson's disease and leads to very difficult but very disabling symptoms. And that's why you'll hear more about it. Particularly, I would say the most common thing is probably the orthostatic hypotension, the lightheadedness, the dizziness when going from sitting to standing. How can Parkinson's disease affect dental problems? An interesting question. I don't know if I've ever got that question before. It depends. And so probably in a lot of different ways. So I don't know, and this I'd have to look up, but I don't know that there's any specific dental problem that comes with Parkinson's disease. However, a lot of things that come with Parkinson's disease can affect dentition. And so what I mean by that is, so Parkinson's disease can affect the salivary glands. So a lot of my patients end up with drooling. Sometimes it's actually dry mouth, and that can affect dentition. Swallowing can also be affected and doesn't work as well. And so sometimes food pockets, which can lead to bacterial overgrowth and sometimes dental problems. Some patients can get a jaw or mouth tremor, which can also impact that. I've had a rare occasion where people get dystonic closure of their jaw and leads to teeth grinding, which can obviously lead to dental problems. You can also get dyskinesia, which oftentimes leads to abnormal mouth and tongue movements, which can also erode kind of the inside of the teeth themselves. And so I guess the short answer to that question is there's actually a lot of different ways that Parkinson's disease can affect the dentition. It's not something that I think about a whole lot, but when I see it, it's definitely something we have to work on. Although I would argue that if it really is causing a lot of dental problems, a dentist is going to be much better at this than I am. Which leads me to something that I always talk about, which I try to make sure I make known, is that even though I am, I don't know, theoretically the Parkinson's disease expert, and a lot of the symptoms that you guys bring up are Parkinson's disease symptoms, does not actually mean that I'm the best person to take care of them. And so what I mean by that is a lot of my patients have vision problems and urinary problems or teeth problems or depression and anxiety or sleep problems. And in all of those cases, there's somebody better at that than I am at taking care of it, even if it is indeed a Parkinson's disease symptom, which it likely is. And so you will see me, or if you're my patient, you are well aware of this, I refer to other people all the time. I send people to dentistry. I send people to psychiatry. I send people to urology. I send people to sleep specialists. I send people to gastroenterologists. And now you can argue, but these are all Parkinson's disease symptoms. How come you can't just take care of them? Well, because I can't know everything about everything, believe it or not, even though I like to think that I do. But there are people who are better at these things, who specialize in these things and can give us some more benefit. And so it's a similar thing for the dental problems. If you really are having dentistry problems, even if it is a Parkinson's disease symptom, a dentist is still probably going to be your best choice. So many choices of exercise. I love this question. Exercise is my absolute favorite thing to talk about. So many choices. Bicycling at greater than 90 revolutions per minute, physical therapy, Tai Chi, dynamic boxing, yoga, which are all choices. If you were still reasonably mobile, which one or ones would you choose? All of the above. That's a cop-out answer. It's not wrong though. I actually don't have a preference for specific exercise. I have my own opinions because I have an opinion on everything, which I'll tell you here in a second. But at the end of the day, all exercise is good exercise. Why do I spend so much time talking about exercise? If you guys are my patients, you already know this, or if you've come to this, you already know this. But if you're new, I never shy away from talking about exercise. It's my absolute favorite topic. Why? Because I can't fix anything, right? I don't have a cure for Parkinson's disease. I don't have a disease modifying therapy in Parkinson's disease, which means I don't have a medicine that slows down disease progression, keeps you better longer, or alters the course. I would love it if I had a medicine that did any of those things, but I don't. And I may be a little bit pessimistic. It's been said more than once in my direction, but I'm not entirely sure that the research community is all that close to any of those either. Maybe. I keep my fingers crossed. I keep hoping, but I haven't seen or heard anything that really has me all that optimistic. I think, even though I say this is proven, it's not actually proven. I think exercise is disease modifying. I think there was some studies that suggested if you were predisposed to get Parkinson's disease, it delayed the onset. I extrapolate that to the fact that it also likely slows down the disease from progressing once you get it. We're working on proving that. I think over at UPMC, they're involved in the SPARKS trial, which is trying to prove that very thing. And I can tell you just from experience that in patient after patient after patient, the ones that exercise are the ones that do the best. And since I don't have a medicine that slows down disease progression or keeps you better longer, and I think exercise does that, this is why I spend so much time talking about exercise. Exercise, in my opinion, does all of the things that the medicines don't. The medicines treat your symptoms, exercise treats your disease. It impacts the underlying brain condition. I believe it keeps you better longer. So that's why I spend so much time in my office, in my clinic, in my practice, in my talks, talking about exercise. It's my absolute favorite choice. Now, if I had to pick what I would do or what you guys should do, I actually have an opinion on that one. So exercises themselves have never been compared head to head, as far as I know. I don't think anybody's ever looked at bicycling versus Tai Chi versus boxing versus walking versus swimming. I don't think there's been a study that really compared head to head or showed one was better or superior than another. My personal opinion is that a combination of things is probably best. So I do think you need some cardiovascular exercise. You need some exercise to get your heart rate up, to break a sweat. I think that is really important. But I also think some resistance training is important. So things that actually strengthen up your muscles, strengthen up your core. So weightlifting, resistance bands, machines at a gym. This is what I mean by resistance training. Things that actually build muscle growth. Throw on top of that some yoga and Tai Chi, which really works on range of motion, stretching, big movements. If you could find a way to incorporate a little bit of all of those, you would have, in my opinion, I think the ideal workout plan. Now, is that proven? Nope, that's just my opinion, but I think it makes sense. I think if you can get the best of all the worlds, you can get your heart rate up enough and break a sweat. You can build your musculature. You can work on stretching and dynamic movements. I don't see how that could possibly be wrong. Is it any better than picking one or doing one more than another? I don't know, but that's just my opinion. It's my talk. You guys are all muted. You have to listen to my opinion. Any thoughts on the new Alzheimer's disease drug? Would it be better for Parkinson's disease patients with cognitive issues? Well, I have thoughts on just about everything, as evidenced. My thoughts are it's iffy. So I've looked at the data on that one, and it's iffy. I personally question whether or not it should have been approved by the FDA, but hey, I wasn't on the panel. I didn't hear the arguments and make the decision. I don't think our cognitive specialists are prescribing it all that often. There's a whole bunch of hoops that you have to jump through to get it, not just in testing, but also it costs an arm and a leg, getting it approved, follow-up testing, monitoring. It's actually very, very difficult to use. And so I'm a little bit skeptical, or I take it back. I'm a lot skeptical of it for Alzheimer's disease, which makes me even more skeptical of using it in my patients where it hasn't been looked at and isn't proven. There are now, and so aducanumab, which I don't even think I can say it because I've never tried. It works on the tau protein. So tau protein is the protein that clumps together and we think is part of the reason that you end up with Alzheimer's disease, which is different than what you get in Parkinson's disease, although there are some tau problems in Parkinson's disease. Generally, we think of Parkinson's disease as an alpha-synuclein protein problem, which is a different protein. But the long story short is they are looking at other similar medicines in Alzheimer's disease, and we are following exactly the same trial course with alpha-synuclein in Parkinson's disease. We've been let down several times already, but they keep pushing this and they keep working on it. And so it's a little bit too soon to tell in terms of whether or not that whole idea is going to pan out. And since I am a skeptical person at nature, I don't believe any of the hype until somebody shows to me a study where it shows that it works. And so the jury's still out. I'm going to wait on that one. I like that. Look at me. Do you see Parkinson's mask? Everybody smiles at me all of a sudden. But that it brings, and I don't know, is the short answer. It brings up an interesting question of the masked face in Parkinson's disease. I often, if you read your notes if you read my note about you, if you're my patient, a lot of time it'll say masked face. So what am I commenting on when I put that in my note, or what am I thinking when I think that? The masked face idea in Parkinson's disease is that because of the stiffness and the slowness of movement, or what's called bradykinesia, you don't have as much facial expression. So you don't blink as much as, again, quote unquote, normal people do. You don't smile as much. You don't laugh as much. An interesting kind of observation Michael J. Fox put in one of his books that I read was that towards the end of his acting career, when he was really starting to have some Parkinson's features and his face was masked, a lot of his co-actors would go up to his manager and say, "Is he mad at me? Like, did I do something?" Because he wasn't having the same bubbly smiling and facial expression. They all thought he was mad at them. He wasn't, but they thought he was. And so it's that kind of loss of facial expression, that lack of facial expression, that I'll put in my note as a masked face. Now it's subjective. And so at the end of the day, it's my opinion as to whether or not I think you have facial masking. Now, again, I probably didn't know what you look like before we dealt with all this stuff. So maybe you didn't really have a lot of facial expression or blinking to begin with. So maybe it's just your face, always possible. But that's the kind of thing that we're talking about from a facial masking standpoint. The short answer is, you specifically, no, I can't say that I see that right now via this picture. But that doesn't mean I won't comment on it, or I won't think it if I see you in the clinic. It is a little bit subjective, and not that anybody's ever come back and say, "Hey, you put this in my note and I don't think that's right." You could. But and especially now everybody wears a mask. So now it's even harder. I'm really looking at this space whatsoever. So, take facial masking with a grain of salt is I guess what I would say. What is the current research on adenosine and its relationship to levodopa therapy? I haven't heard anything in the research world on it. Adenosine's actually been looked at for a little while now. I feel like I remember hearing about it when I was a fellow. And so unfortunately, I'm getting older. And so now we're going back a ways. But I honestly haven't heard anything new. So maybe I need to go looking. If you've heard something new, type it into the chat box and I'll go look it up. But I haven't heard anything new. I don't really remember it panning out in the past, but maybe if somebody's asking a question, maybe I need to go back and look it up again. That's a great question. How many patients will you or your partner see in a day? How do you suggest patients prep to max their time in your office? What a great question. I see a lot of patients. So let me give you a little bit of a behind the scenes insight into a day in my life, and probably most doctors' life if you go to enough doctors. So we all have ridiculously packed schedules. So if anybody's tried to get in my office recently, you know this. And every day is ridiculously packed. It's not like I'm scheduling so far out because I only see 3 people a day. That's, believe it or not the case. So generally, and this is true for my office, I'll just use my office as the example. I don't want to comment on other people's clinics because I'm not sure how they run things. But the short answer is, in my office, I have 40 minutes for a new patient and I have 20 minutes for a return. And basically that starts at 8 and goes to 4. And sometimes they let me eat lunch, sometimes they don't. And so I can have anywhere from 16 or 17 patients to 23, 24 patients, depending on how many they've crammed in, how many are new, how many are returns. That's a lot of people in a day. And you literally get 20 minutes, period. So how do you maximize that time? How do I maximize that time? How do you maximize that time? Because it is a group effort. Probably the best way to maximize that time is to show up early. I know we tell every patient, at least at Allegheny Health Network, we tell every patient to show up 15 minutes early. Very few people do. But if you do, it oftentimes, not always, don't hold me to this, but it oftentimes allows us to get you into the room and allows the medical assistant to get all of their stuff done so that I can sort of start on time. Because what ends up happening is people show up right at their appointment time, and then the medical assistant has to get them into the office and get their medicines and check their blood pressure and their heart rate, which we have great medical assistants, but it takes time. And so by the time I get in there, now we're down to 13 minutes. Not ideal. And so step number 1 is show up on time or early if you can. Step number 2 is make sure, and this is just kind of general rules of thumb that I would tell everybody, is have a list of your medicines. Have a list of what you're taking, dosage, how many times a day you're taking it. You should always have an active list of medicines on you at all times, because you never know when you're going to get hit by a car and end up in the emergency. Please don't go get hit by a car, but you never know when you're going to get hit by a car and end up in the emergency room, and nobody's going to know what's going on with you. If you have it on you, they will know exactly what you're taking. The other thing, and there's a lot of things you can do, but kind of the last thing that I think is the most helpful is have a fairly narrowed down list of questions. 20 minutes is not a lot of time. 20 minutes with me can seem like a really long time. I can be that bad, but 20 minutes is not a long time. And so in order to try to make sure we cover everything that you want to talk about, having a list and a concise list of things that you want to talk about is important. One of the things that tends to drive me crazy, and I'm pretty sure it's not just me, but maybe it's just me, is that we go through the visits, there's no list of questions. We talk about the problems and I'm like, okay, this is what we're going to do. This is what I'm going to see you back. Let me go make it happen. And I get up to, and it's like, oh, one more thing. Oh, I remembered one more thing. And so four more things later, after I've tried to get out the door, now everybody's kind of jumbled and it's driving everybody's crazy. And so again, the best thing you can do is kind of be concise and have a list of questions, things that you want to talk about while we're in the office. Because guess what? I'm not a mind reader, even though I pretend to be a mind reader, and maybe I play a mind reader on TV. I'm not actually a mind reader. And so if you don't ask the question when you're in the office, I don't know it's a problem. And I hate for us to go through an appointment and try to answer all the questions, only for you to either hit the waiting room or hit the car or get back home and be like, I should have asked about whatever, because then nobody's happy. And then you have to send me a message. And yes, I do try to answer messages as best I can, but everybody knows how long that takes, and it's not nearly as efficient. So the things I would say is show up early, have a good list of medicines that's accurate, and have a concise list of questions that you really want to talk about. Those, I think, would probably be the best thing to help us be the most efficient. I love that question, though. That is a great question. What about amantadine? What about amantadine? I'm going to assume that was going back to, do I like amantadine? What do we use it for? I love amantadine. I use amantadine all the time. So historical fact, amantadine is an old drug. Amantadine was initially invented for the flu. It's not a very good flu medicine, but back in the day when people were taking it for the flu, particularly people with Parkinson's disease, they noticed that they were less shaky, less stiff, and they were a little bit better balanced. Amantadine works actually in a whole bunch of different actions, not just as directly dopamine producing or correcting as some of the other medicines do, and that's why I like it. It actually works, in my opinion, a little bit more on walking in balance than, say, levodopa or pramipexole do. It's the one medicine that we have that helps people do better, but decreases dyskinesias. So Gocovri is a long-acting amantadine that is specifically approved for the dyskinesias in Parkinson's disease, but I think amantadine does too. So amantadine does have some specific roles in treatment of my patients, and you will see me use it a lot. I do like that medicine. It has side effects. Don't get me wrong. Every single medicine that I use has side effects. But at the end of the day, I do use a lot of amantadine for things like dyskinesias, for things like walking imbalance, for things, like tremors or trying to get people doing better. And again, it's individualized. And so believe me, if I think amantadine is the right choice for you, that's what I'm going to put you on. And if I don't think amantadine is the right choice for you, I'm not going to. And so again, one of the things that I want to make known to everybody in this meeting is no two people are the same thing. And so you might, go kind of check notes with somebody else and say, well, hey, how come you put me on this and you on this? Well, it's because we were trying to accomplish different things, or it's a completely different circumstance or situation. And so you do have to recognize that. But the short answer is I use amantadine a lot, and I think it's a very useful medication. Knee surgery and Parkinson's disease, problematic and ouch. Definitely ouch. I mean, I've never had a knee replacement or knee surgery, but nobody's ever told me, hey, that was a lot of fun. It does seem painful, and the therapy seems painful, but super important. Is it problematic? Yes and no. I know. That's actually the first wishy-washy answer I've given today. You guys should be proud of me. Is it problematic? Yeah, any surgery is not good for the brain. Again, they're not just going to give you a shot of whiskey and a stick to bite on for a knee replacement where they have to cut open your knee and chop off your bone and replace it. I'm not a surgeon for a reason, believe me. That is not my area of expertise. I'm a terrible surgeon. Is that bad for your brain? I mean, it's probably not great for your brain. Anesthesia is not great for your brain. Being laid up isn't good for Parkinson's disease in general. But is it useful? Well, maybe. If you're somebody who's not exercising because your knee is killing you, then it's absolutely important that we fix it, because exercise is such an important treatment for Parkinson's disease that if you're not exercising, whatever the reason is, we need to fix it. And if it's your knee, then I'm all for knee replacement surgery. If that's what it's going to take to get you to being more active, I would rather take the price of knee surgery with the end result of you being active than you not having surgery and not getting up and moving. I think I said that correctly. Because at the end of the day, in my opinion, exercise is such the most important thing for each and every one of you and me, that if there is anything that gets in the way of you being able to get up and exercise, i.e., if there are any excuses, then we have to find a way around those excuses, because not exercising it's not a choice, but if it is a choice, it's the absolute worst choice. And so again, yes, there's a lot of extenuating variables there, but if a knee surgery allows you to get up and move and do more exercise, I'm all for it, as long as there's nothing else that's going to be a problem with it or minimize the other risks. But that's how I view all surgeries. I don't want you to just go have surgery because surgeons like to fix things. That's a terrible idea. But if there is a discrete goal of either exercise or getting you up or moving, and surgery is a way to do it, I am all for it. With all these pains you talk about, how do you know if it's caused by Parkinson's? I don't know anything, which sounds silly, but I don't. I have no evidence for anything. I have no test for anything. I have no definitive black and white answers for anything. You can kind of extrapolate. So again, certain things are probably caused by certain other things. Again, if you come in with a knee problem, I'm going to tell you it's probably because your mechanics aren't right for Parkinson's disease. If you come in with dystonic posturing and it hurts, I'm going to tell you that's probably from Parkinson's disease. If you tell me, hey, it randomly hurts right here, I'm going to look for something else. And so the short answer to that question is I honestly don't know if it's definitively caused by Parkinson's disease, but this is why asking more questions and trying to get to the certain circumstances in which the things are happening really help us try to answer that question. What is the best way to control freezing of gait? Well, you know my answer. Everybody in my entire office knows the answer is going to be exercise. But I recognize that's easier said than done. Freezing of gait is a significant problem. And so not everybody knows what freezing of gait means, but what I mean by freezing of gait, or what generally we think about in terms of freezing of gait, is exactly what it sounds like. So either when you first stand up, you can't initiate a step, or even mid walking, you stop and you can't move, at least for a short period. That's what we usually think about in terms of freezing of gait. The reason why freezing of gait is such a problem is it leads to falls. And again, falls are absolutely the most dangerous problem for any of us. Falls are really the number one way my patients end up in the hospital. And believe me, the hospital is not where you want to end up. Nothing good happens to my patients when they're in the hospital. And so freezing of gait is a big issue. Now, again, similar to the pain idea, we do have to ask more questions. Is it related to medicine? Do you freeze when you wear off, in which case you probably need more medicine? Do you freeze when you're at peak? Okay, maybe we need to decrease. You will see me sometimes use things like amantadine, even though there's no evidence to suggest that amantadine is any better than any other ones. Sometimes you'll see me use outside of the box things like methylphenidate or other things that really don't have good data. But because freezing of gait is such an issue, we got to try everything I can think of to see if we can avoid it. The best thing for freezing of gait is physical therapy and cueing. Now, that doesn't necessarily keep you from freezing, but it does help you when you do freeze. So cueing is using some sort of cue, either counting numbers 1, 2, 1, 2, left, right, metronome, music. Doesn't matter what the cue itself, which is this vibrating thing that is available in Europe, which I haven't got a question about, but I'm waiting for it. Still haven't heard if it's available in this country yet. But all of these things are cueing. So cueing is the best way to help you get unstuck once you get stuck. And so again, that doesn't help control freezing. That doesn't mitigate freezing, but it at least helps us prevent you from falling if you do freeze and getting you from unstuck. But really, physical therapy and exercise, working on walking, paying attention, so not multitasking, although at the end of the day, dual task therapy does help. So where you practice multitasking does help. These are probably the best ways to try to work on freezing, unless it really is related to medications. If it's related to wearing off or things like that, then maybe that's a bit easier. But in my experience, I would suggest that that's not usually the solution. That doesn't usually fix it. Can low back pain be caused by Parkinson's disease? Of course it can. For a lot of reasons. Due to back muscles not fully working as they should, yes. Again, your posture is bad, so you tend to be flexed forward, so that leads to a lot of back pain, neck pain. Also, an interesting thing is that, and a lot of you have probably noticed this, is that your left and right don't do the same thing. And a lot of people notice this early on, but even as you progress, usually whatever side it started on stays worse throughout. And so that's true in the spine column too. You can actually get more cramping or more more spasms, more increased tone, more rigidity on one side versus the other. And that asymmetry also wreaks havoc on your spine, which is built to be, straight up and down. And so a lot of the things that you can get in Parkinson's disease can cause back pain, no doubt about it. And again, all of these things can be worked on. I send a ton of patients to physical therapy. There's a reason I have a physical therapist in my Parkinson's disease clinic, because they're so important for helping people with things like this. I do send a lot of patients to the pain clinic to get shots, to get ablations, to get, rhizotomies, things like that. I send people to surgeons too, although I am not a huge fan of back surgery if it can be avoided. Obviously, it's needed at times, but it's definitely not my favorite first choice. And I would make sure that we know exactly what we're doing before we get to there. And so, yep, low back pain is a big problem, not just in Parkinson's disease, in the world at large, but also in Parkinson's disease for a variety of those reasons. How often should you exercise, and can you exercise too much? Unfortunately, while I would love to say, no, you can't exercise too much, I have to be a little bit honest. So you don't want to hurt yourself. So the short answer to the question is as much exercise as you can do without hurting yourself. Okay. And so what do I mean by that? Well, exercise is good to a point, right? If you're straining muscles, if you're tearing muscles, if you're doing so much exercise that you can't function the next day, well, then it's not really doing that much good. You can overdo it for exercise. But outside of that, outside of hurting yourself, outside of, stressing and straining muscles or really paying for it to the point where you're not functioning the rest of that day, the next day, the next 2 days, you really can't overdo it from an exercise standpoint. So there were a couple of studies that came out that actually tried to specifically answer this question. They both came up with a general idea, which is what the CDC actually recommends in its guidelines, which is 150 minutes a week of exercise to get your heart rate up. Now, what they came up with, which people often forget about, is that that's actually the minimum. That's the minimum amount of exercise to really get the protective brain changes that we think. And there is actually no maximum outside of, again, hurting yourself. And I say recently, it could have been yesterday, it could have been 6 months ago. That's all pretty much the same thing in my brain right now. But recently I read something that suggested that probably double that. So maybe, 300 minutes a week is really what we should be aiming for. But again, you can imagine how that's a lot of exercise, right? I mean, even 150 minutes a week, 30 minutes a day, 5 days a week is probably more exercise than I would say 90% of this country is doing. Maybe even 95% of this country is doing. Not a lot of people are actually doing that much. That is a ton of time spent exercising. And if you try doubling that, it's even more. But you got to have a goal and you got to have a number in mind. And that really is the number that we quote, or that I'll quote to you in the clinic, because that's what a couple of studies have come up with. But the short answer is exercise is a great thing, right? Even let's say you can't hit 150 minutes a week, you can only do 45 minutes a week. That's still better than nothing, right? 10 minutes a day is better than nothing a day. Obviously 20 minutes is better than 10, but as much as you can do is really what we're aiming for. What I don't want is say, okay, you have to hit a half hour a day, 5 days a week, or it's not worth doing it at all. That is definitely not the message. I hope nobody gets that message. All exercise is good exercise. And so as much as you can do is really what we're aiming for. Now, don't hurt yourself. You're not allowed to fall. Don't put yourself out of commission for a day or two, but be as active as you can. All activity is better than no activity. True exercise, in my opinion, is better than just activity. But again, as much of these things as you can do is really what's going to help you do the best. And I can just tell you time and time again. So I've been in this position for, I think I'm in my 9th year. I've taken care of, I forget the number, but more than 4,000 patients in these 9 years. And I can tell you time and time and time again, the people that exercise do the best. Plain and simple. As active as you can be, that's what's going to help you out the most. Playing pickleball really helps me. Pickleball is great exercise. Again, I'm not against it, and it's a little bit competitive, which gets the dopamine flowing when you win. And so at the end of the day, all exercise is good exercise. If you like pickleball, go play pickleball. What I usually tell my patients is find something you like to do, because if you like to do it, it will be much more easy to do it, and I won't have to yell at you as much, and you'll do it more. Find something you enjoy to do. All right. Well, I think I'm getting to the end, and I got one more question, so I'll finish with this question. And believe it or not, Casey, I may end up just on time. Can you take too many pills in a day of levodopa? I guess it depends on how you define it. So the short answer is there is actually, at least as far as I know, no documented maximum dose of levodopa. I don't think. So realistically, no, you can't take too many, except for the fact that eventually you're going to run into side effects, and side effects are really your rate limiting steps, right? So when you start having hallucinations and dyskinesias and motor fluctuations and things like that, or you have to take pills every hour, hour and a half, then it's not as helpful as you think. And so is that too much pills? Well, no, but it is a problem or a side effect of the medicine. And so then we need to think of a different strategy. And so the short answer to that question is no, you can't take too many pills, except for you're on too many pills if you're having side effects or if there's problems. And then we need to think of a different strategy to figure out what we're going to do. One more question snuck in, Casey. I'm gonna answer it, and then I'll be done. Maybe. Given the many years before clinical diagnosis, common prodromal symptoms, is there any benefit from an earlier diagnosis? Is there a role of earlier DAT scan in patients who may be heading for Parkinson's disease? I'm going to again throw out a yes and no answer. The easy answer would be to say no. So what does he mean by prodromal symptoms of Parkinson's disease? So there's a few things that predate the motor symptoms of Parkinson's disease. So the motor symptoms are the tremors, the stiffness, the slowness of movement, the balance problems. The non-motor symptoms are everything else. And the premotor symptoms are things that come before the motor symptoms. Generally, the three that I always ask about are loss of sense of smell, talking in your sleep, also called REM behavior sleep disorder, and constipation. These are the three most common. They're the ones that have been most written about. But depression, anxiety, things like that can also be there. And we think, particularly REM behavior sleep disorder, which is acting out dreams, fighting, kicking, yelling in your sleep, very, very, very frequently goes on to develop Parkinson's disease. And yes, when you have those patients, a DAT scan can be abnormal to suggest that is heading towards a Parkinson's syndrome. A DAT scan is not a specific test for Parkinson's disease. It only tells you you're in the right ballpark. But is that helpful? And the short answer is no. And the answer is no, but I'm going to come back to why it's actually yes in a second. The answer is no, because I don't have anything that alters the course. I do not have a disease modifying therapy. I do not have anything that if I start it early or sooner that you do better, at least not proven. And so the answer is no, because even if I could diagnose somebody in childhood, hey, in 50 years, you are going to develop Parkinson's disease, there is nothing I can do to stop it from happening 50 years later. It's going to happen no matter what I do. I don't have a medicine or a disease modifying thing that alters that. So that's why the short answer is no. However, could that information be useful? Hey, all of a sudden I'm telling you, I think you're going to develop Parkinson's disease. You really need to start exercising. You really need to start focusing on fitness. You really need to start being healthier and making better choices so that when it does come, maybe you have a slower progression. Maybe you do better. Maybe it doesn't hit you as early as it would. Maybe. Would that just scare people knowing what's coming? Maybe. So the short answer is no, but maybe there is some potential benefit if we could use it in that fact. Now, I don't routinely send people for DAT scans with those prodromal symptoms or thinking that, oh, this is going to prove that you're going to have Parkinson's disease. I don't even really see a lot of people. I have a couple of people who come to me purely for REM behavior sleep disorder, but I don't have a lot of people that just come to me with prodromal symptoms. This would really have to go back to the primary care doctor level and people who are taking care of people with these problems. And so it does get a little bit trickier than that, but it's an interesting concept. And yes, if and when we do end up with medications or treatments that are disease modifying, well, then I have to answer that question completely different. Then it's much more important that I diagnose people as soon as possible and we get you on the medicine that is disease modifying as soon as possible. And believe me, I can't wait for that day to happen. All right, Casey, I think I'm going to stop there and I'm going to pass it back to you.
Thank you. Wow, that was pretty amazing. Always learning so much. Thank you, Dr. Leichliter. Thank you. Thank you.